Well, hello there. Welcome to the BPharmHons and Experiential Learning Ethos deck. My name is Doreen Tan and I am the Faculty Advisor for PCT. I will be your host for the coming slides. Well, you might be thinking, why do we need to change in Singapore? What are the winds of change for pharmacy in Singapore? Well, pharmacy practice is rapidly changing. Automation and distribution processes are probably the first few things that come to mind. Many of these automation processes are displacing the traditional functions of pharmacists in the supply of medications. What about the shift of care to the community as we respond to the call of the Minister of Health? Due to the rising healthcare cost, it is believed that if we move the care to the community, we can save money for the healthcare system. There's also an expansion of roles in public health and an aging population with arguably better and more ways of diagnosis and more treatment. This has resulted in polypharmacy in our aging population of our patients. Now, pharmacy education has changed in the top pharmacy schools in the US, the UK, Ireland, and Australia. Why don't we also change now? So how do we plan to train our undergraduates differently? The educational outcomes of the new NUS B.Pharm program is adapted from the Canadian AFPC Educational Outcomes Framework. And this AFPC framework comprises 7 roles of a pharmacist. And essentially you can look at how the care provider is central to all the other 6 roles that build towards the care provider, which is really the person that everyone sees. The 6 other roles, the professional, the collaborator, the communicator, the leader manager, the scholar innovator, as well as the health advocate, all of these are critical roles and learning outcomes that we have built into our syllabus, intentionally weaving them as learning outcomes throughout all the 4 years of our students' undergrad lives. So what really is this integrated approach? Basically, we are looking at 3 pillars of how integrations are going to be. Gone are the days of the past where we would do our subjects in little silos, like anatomy as one subject, physiology as one subject, pharmacology as one subject. Now we have intentionally woven all these subjects together in the form of how we deliver our content. So the pharmaceutical sciences are interwoven with the biomedical sciences, the clinical sciences, and system sciences. So here's a slide of all the organ systems that our undergraduate students will go through throughout the 3 to 4 years of their undergraduate life. So they'll start off in the year 1 with integumentary and ocular systems. They'll move to gastrointestinal systems and cardiovascular system in year 2 and SEM 1. In SEM 2, they will go through respiratory system, hepatic and renal systems. By year 3, they'll go through infection control, immune and endocrine systems, and by the second semester, they would have covered central nervous system as well as heme and musculoskeletal systems. Now you can see how we have interwoven all the 4 sciences into all these science and therapeutics organ systems. Let us consider an example of an integrated module with the CVS system. The prevention and management of cardiovascular diseases will be the main focus of the CVS module. Biomedical sciences would ask the question, what happens to the heart and blood vessels in cardiac failure or hypertension? The pharmaceutical sciences would step in and teach the students about the chemical and physical properties that differentiates the non-dihydropyridines with the dihydropyridines. Subsequently, the clinical sciences would come in and ask the question, how do we devise a care plan for this patient? What are the barriers to compliance to statins? And then the system sciences would step in to think about how to prevent the onset of cardiovascular diseases in the first place, and this is really very much population health. They also will be teaching the question on whether Entresto, for example, is more cost-effective than lisinopril in heart failure. What is a health system? Well, in the 21st century, we have to understand that there's so many roles and responsibilities because of the aging population who are getting more and more diagnosis and polytreatments as well as polypharmacy. All our roles are interdependent, and that's what causes a healthcare system to be formed. So instead of working in silos, it's critically important for us to understand how the healthcare system works, to understand the workflows and how we relate to one another. Let's just say, can we do things without involving our GP friends? Can we do things without involving our social setups like Fei and many other social enterprises? The answer is readily no, because if we do not knit up the network of supportive care for our patients, we'll all be duplicating all their capabilities and will always be very, very expensive as a healthcare system. Those of us who work in a healthcare institution would probably not need an introduction to how Singapore has been split up into 3 different clusters. Now, all these clusters have an amalgamation of various different services and settings, and this all the more reinforces the importance of helping our students understand the bigger picture of how things all knit together, and then reflect on their roles as a pharmacist in the various settings, in the various setups, all across the island. So beyond the disease modules, you would see that our students will be developing professional identity development as well as patient care skills. The traditional laboratory-based skills development practicums will still happen. With that, we've also weaved in small group reflection and discussion sessions in the form of a collaborative learning workshop, which is woven into the disease modules. All this will serve to develop the values, attitudes, skills, and behaviors as core concepts of the undergrad syllabus. Is that enough? Oh no! We're going to integrate all these things with PCT as well, and utilizing the COPE's experiential learning cycle as a pedagogy, we want our students to go out, to experience, to see activities on their own, practice reflective observation by reflecting to themselves on the activity or experience, and then conceptualize the new skills or knowledge from the experience and think about how they want to experiment it, to learn, to do new things and new capabilities. And as they come back to class, this will also write on to whatever they've learned, reinforce the techniques that they've learned, reinforce the knowledge, and then put them in a better state to be in a better position to receive more new knowledge in a more complex setting. Here's more on how COPE's experiential learning cycle will work. The classroom-based concepts are traditional to what we already know, where there's PID, there's applied skills, as well as science and therapeutics that happens in class. And then when they go on-site, there's an experiential component, which is systems-based. They will then learn clinical training as well as on-site pre-employment training supervised by practicing pharmacists in the context of where they work. All this will work in partnership in order to help our students grow in their professional journey. So the competency-based learning that you saw in the earlier slide are actually all woven into the undergrad syllabus. And in the 3rd year, they will now have a discovery project year. And this will build further the skills of a scholar innovator in our students. A closer look at the National Developmental Framework for Pharmacists will show you that the domains that are listed on the left-hand side is almost completely identical to the 7 roles that we're trying to build as an undergrad syllabus. Work has already been done, and all this will dovetail nicely into the developmental framework for the pharmacists as they come out to practice as well. So let's talk a little bit deeper about the education and training continuum for pharmacists. So here's the timeline from undergraduate all the way to advanced practice. The developmental framework for pharmacists that we discussed earlier clearly will govern the time from which a person is registered, but that's topic for another day. Let's talk about the earlier part that leads up to registration, and that's to do with the undergrad syllabus as well as pre-registration training, governing the entry to practice competency standards for pharmacists. So PCT1 is what we're talking about today, which is completely brand new. So what is this? It's basically a workplace-based activity and experiential learning that happens from years 1 to 3 of an undergraduate syllabus and training. The intent is to develop competency through classroom and experiential learning through the COPE's learning cycle as we've discussed earlier. Now, PCT1 does not count towards pre-registration, whereas PCT2, which is what we're familiar with today, comprising of the 2 12-week rotations, will still count towards pre-registration, and then following that, the trainee enters pre-registration training and then becomes a registered pharmacist. So you might be wondering why on earth we're talking about the continuum of education and training. I basically wanted to bring up this particular curve that was published by Khan et al. And modified from Dreyfus and Dreyfus. Now, to become a competent pharmacist, there are many performance layers that we need to go through. Now, for undergraduates, I just want to remind everyone they are no better than laypersons when they first enter the first year of training. Now, the younger the pharmacy student is when they come to you, the more we have to realize that we are training them from scratch. And essentially, we're training them to be, by the end of PCT 1, to really be a novice level, which is really protocol-based performance of a skill that could be actually in isolation from the other tasks. By the time they enter PCT 2, they would probably be perhaps an advanced beginner, and hopefully by the time they finish their pre-reg, they would then be competent practitioners. So let's explore deeper on how the 7 roles are intricately woven into the experiential learning journey for our undergrad students. So for the first year, they'll be exploring concepts in the classroom about who the pharmacist is, what do the rest of the healthcare team members do. They'll be taught reflection writing exercises and what the professional identification of a professional pharmacist is going to be. They will also be learning concepts on how to keep healthy and age well. A lot of the knowledge that they will acquire will be about keeping the weight down, lowering the salt intake, and potentially home BP monitoring, and when to advise the auntie how to age well. So the roles of the health advocate as well as a professional is very critical in this first year. Subsequently, when they get to the second year, they'll be thinking about how they're a member of the healthcare team. A lot of the activities that they get exposed to will potentially be in the ambulatory care setting, for example, in the polyclinics. They will be learning community activities and models of care, and in this year, they will start to learn to develop compassion. In the syllabus, they will also be learning selecting blood pressure medicines and keeping the CVD away. In this year, they will explore what matters to a layperson the most. Here, we'll hone the roles of a communicator as well as a care provider, not forgetting the health advocate as well as a professional, and the earlier ideas of collaborator and leader manager will be built in the second year. By the time they get to the third year, they'll be exposed to the acute care setting, and they will really be thinking about the theme of person-centered care in the acute and complex person. Here, they'll learn concepts of the transitions of care in safety, medications review, and drug-related problems. They'll be thinking about how to enunciate the role of biologics to funders and potentially the patients. They will also be looking at potentially activities that a pharmacist can lead, like here in the meeting where a pharmacist is conducting a pandemic exercise, or maybe in a setting of the drug shortages where a pharmacist commands the operations of something as complex as that. This year, we'll be honing the skills of a collaborator and leader manager, not forgetting the other roles that we've developed before. Also in the third year, they will have to go through a discovery project experience where the scholar innovator is going to be developed. By the time they get to the year 4, that's where PCT 2 is going to be, and after that they get into pre-reg and they reach the goal of being role model pharmacists like Kai Keong and Wing Lam in the picture on the top right hand corner. So how would an experiential learning activity look like? For example, in the second year, in Block 3, they'll be going out to observe a dispensary. So using the COPE's experiential learning cycle, what happens is they will learn the theory in class, potentially by skills, and then there will be an activity sheet provided to the student. Now, all activities in the PECT 1 program will be governed by an activity sheet, which puts in all the learning outcomes that students must observe, that also guides the facilitators at the sites. Prior to the attachments, they will be asked to recall steps for taking a medication history, for example. And maybe in this exercise, because the pharmacist is teaching how to use an inhaler, they will be asked to review how to dispense an inhaler under the preparation of the activity sheets provided to the student. Subsequently, they'll be guiding questions in the activity sheets to ask them to think about how they felt, like after the observation, how do they feel about the language, the pace, the tone, and non-verbal communication that's used by a pharmacist. And this is an example of how the communicator role is being brought out by this activity. And then after the whole day is over, at the reflection step of things, they'll be asked questions like, how would you change your language or approach if there were various scenarios that govern the necessity to change their approach to a patient? And there'll also be activity blocks that will be debriefed in class. For example, in the first year, there is an interview of pharmacists activity where they have been sent out to interview 32 different pharmacists from the various sectors. This will then be debriefed back in class when they bring back all the information that they've learned from the particular interview exercise and put them together. Collectively as a class, they will be able to see across all the 32 pharmacists and learn from one another more effectively and optimize classroom experience. Here's a screenshot of how the educational outcomes look, just to give you a sense of the descriptors that we've written into learning outcomes, both for our syllabus as well as for experiential learning. So the PEC 1 Subcom 1 that's led by Prof. Christine Teng and Ms. Goh Jining of Ng Cheng Foong Hospital have come up with a crosswalk that bless their hearts to cross-link the learning outcomes, the competencies, as well as the 11 EPAs that was drafted for the National Framework of Pre-Registration Training. So because the EPAs are under review, we have not called them out to be part of the assessment criteria. However, we want our pharmacy students to be exposed to the EPAs and what the key activities that we need them to be entrusted with. So this particular crosswalk would then enforce to make sure that all the competencies are being taken care of from year 1 to 3 and that nothing is going to be left out. What are the key milestones that will impact our students and the facilitators? The first thing that students would do every single year is to declare the fitness to practice as well as confidentiality declarations. Subsequently, there will be a PCT1 onboarding for especially the year ones as they enter the program to tell them about the overview, the rationale, expectations, as well as assessments that's involved in PCT1. Subsequently, just before every single block, if there are activity-specific briefing, it will be done via pre-recording in Luminous, and the details, administration, as well as learning outcomes will be told to them prior to the activity. If you can see in the green boxes above the timeline, there are activity blocks that are described for year 2 type activities this particular year. Subsequently, after every single block, there will be activity-specific reports, debrief, and reflection exercises, and any concerns with professionalism or no-show must be reported to the NUS Clinical Training Officer immediately. After every block, we would request for our facilitators to give us the professionalism feedback form and debriefing and reflection on site by the facilitator or chief facilitator and supported by the activity sheets. We would like also an annual written graded reflection exercises in class for our students. At the end of this particular academic year in year 2, there will be year-end attendance report. There will also be assessments that will be done, which include the professionalism form exercises, the PECT, PharmS and Dream surveys, the facilitator and student feedback survey, as well as the students' nomination for the Staff Facilitator Award. So here's an inventory for the Phase 1 PCT1 rollout, including the details on year 1, which is preceded by 1, and the dot talks about the block number or the sequence in which the activities will occur. So year 1 activities are 1.1, 1.2, and 1.3, and the year 2 activities are 2.1, 2.2, and 2.3. Here are the various anatomical landmarks for the activity sheets. To start off, Section A is always about the student handout, and it describes to the students what's expected of them with respects to the key activities as well as learning outcomes, as you can see in the screenshot over here. The second part is on reflection, where there's a Gibbs learning cycle that is put out for the students, and this Gibbs learning cycle has got some suggested questions for the facilitators to take our students through. There's also a navigator map for the students under the Health Advocate rule. For example, for this particular activity sheet, because it involves health peers in the year 1, it basically helps our students connect the dots between the year 1, year 2, and year 3 activities and how the health advocacy skills that they're learning can be expanded into different levels of complexity of patients. Lastly, there's also Part B, which is for the facilitators or for school, which is NUS, and these are notes written by Subcom 1 to communicate to Subcom 2 about the requirements for the sites and what are the key things to take note of. For Part C, it really is just for the engagement team like Subcom 2, and so likely for the students, the whole activity sheet will end at the navigator map, whereas for the facilitator view will also have parts B and C that is part of the whole activity sheets that is shared with them. So taking everyone to a further block, which is 1.3 or health advocacy, basically the description is put here, and then the learning outcomes are listed on the right hand side. So these are the learning outcomes that we want our students to develop. Essentially, this whole thing will guide our facilitators through the whole program. So the PCT1 phased approach is as such. For this year, when we rolled out, we are likely to have 3 blocks in year 2 and none in year 3 because the students haven't gotten to year 3 yet. For phase 1, we are likely to have 4 to 5 hours per block, and there will be 7 blocks comprising of the year 1 activities, total of 3, and year 2 activities, total of 4. Once year 2 comes about, which is August 2022, we plan to roll out 8 blocks in year 3 and potentially expand the year 2 blocks to 8 days as well. And then by steady state, we're likely to get to a total of 36 blocks. We're not entirely sure where we get to steady state yet, but we're looking forward to that. So for phase 2, we're talking about 19 blocks that's proposed, and for each year, we're likely to have between 150 to 160 students. So the PCT1 is overseen by an oversight committee, which comprises of all the NUHS pharmacy heads, because we have started rollout in NUHS first. Essentially, there are also 3 subcommittees that I keep alluding to, and those subcommittees are led by Subcom 1, Prof. Christine Ting and Ms. Goh Chuning, which talks about the framework and standards. Subcom 2 is led by me and Shanti, and we basically govern the facilitator and site engagement. And Subcom 3 is led by Leroy and Paying from the AH setting, and this subcom takes care of assessment and quality assurance. This is a quick look of the terms of reference for the various subcoms, and essentially you can see why there is a need for 3 subcoms, so there's a check and balance between the 3 subcoms. So closing this whole sharing, I just want to share this picture, and sometimes depicts how I feel about the whole journey as a faculty advisor of PCT1. It's like this whole place is an open ground, and building something out of nothing is really something quite remarkable. The footprints in the sand that we've left also reminds me of the challenges and the difficulties we've faced as the various subcom and the heads of pharmacy of all the NUHS institutions. And I'm just very grateful for the whole community of practice that's been supporting us in our journey. Sometimes there are many road signs and things can get confusing, and it really is about an ongoing review process and learning from all our experiences. We can never let perfect be the enemy of good. So below is a schema of how the steady state is going to look like where 36 blocks is concerned. We don't know when we'll get there, in which year, but I certainly know that there's a whole body of you that's supporting this whole initiative, and together we can build a very good environment for our undergrad students to become future ready pharmacists. So I look forward to your cooperation and your collaboration and your help. With that, I thank you for listening. If you have feedback or questions about our students, please contact us at the email below, and this one will be answered by our Clinical Training Officer, Ms. Adrienne Yam. And for me, I'm the Faculty Advisor for the Total PECT program. Please feel free to feedback to me if you had suggestions or questions. Thank you very much.